Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a very important guest that hopefully will help us PEM providers deal with a very important topic, the topic of the newborn baby with first presentation of metabolic disease. Metabolic diseases, fortunately, are not very common. And fortunately, we don't see those very often, which is a double-edged sword. It also means we're not very familiar with them, and those can easily be missed, which is why I invited Dr. Austin Larson, a metabolic specialist from the Children's Hospital of Colorado, to help us navigate and learn how to identify those kids and how to treat them appropriately in the Pediatric ER. Welcome, Austin, to the show. I appreciate your time. I know you work in a very, very big academic center, so I'm sure you're very busy. We planned that months in advance because Austin is such a busy doctor, so I really appreciate it. And let me just introduce you to the PEM Rules listeners, and you're going to stop me at any point if I said something incorrect. Austin, you're originally from Denver, Colorado. You went to medical school at Brown University and did your pediatric residency and your genetics and biochemical genetics fellowship at the University of Colorado back home. Currently, you work as an associate professor in pediatrics at the University of Colorado and practices at Children's Hospital of Colorado, which is a very, very big children's hospital. And when you're not practicing medicine, I guess you like to jog a lot. Is that right?
That's right. Yeah, pro running.
How long do you go? I just came from the gym today. I do 1 mile and then I go back home. What do you do?
I will do ultra marathons. So 50 or 100 mile distance occasionally.
Oh, wow. And that takes you how long?
Really depends on the terrain. So it's all about the footing and the elevation. Those can be pretty long runs.
Excellent. Very nice. So again, thank you very much for coming on the show. I'll say briefly, all of us who take care of children in the ER know that metabolic diseases are really like a challenge on their own. They are, the pathophysiology is often quite complicated and something that involves basic science that we all forgot about. And I think the biggest challenge for me, is there are far and few in between. So we don't see those very often. So it's kind of easy to forget about something you don't do very often. So I really appreciate your time. I think the PEM Rules listeners can really benefit from your wisdom. And the first question is the one I ask all my guests. Everybody has their own perspective, which is interesting. Austin, what is your definition of a good PEM provider? One who does what?
Yeah, so I really, really value the expertise and the experience of the emergency providers that I work with here. So I've had a longstanding clinical collaboration with a lot of the PEM physicians here at Children's Colorado. I've really come to respect and admire the ability to kind of balance algorithmic thinking with clinical intuition. Knowing when to rely on one versus the other, being able to gather information in a really kind of time-sensitive way, in a way that's sensitive to patient distress, which is really important in pediatrics, and then to access specialty expertise to know who to call in which scenarios and what information to give them to get the right answer for your patient.
I agree. Thank you very much for that. It's actually one of my rules when you call a consultant, give them a good story. I think I can see how it can be a very big challenge to sit at home. And if I don't give you a good story, it's very hard to give a good advice. So I certainly can relate to that. Thank you for that. And regarding metabolic diseases and the things that come with it, I teach a lot of pediatric emergency medicine. And one of the reasons one of the things I like to teach the most, because I think a lot of residents are intimidated by emergency medicine, is that pediatric emergency medicine is simple. Usually all I have to do is 2 things on every patient. I have to provide acute care, and then I have to decide on the appropriate disposition. Somewhere in the middle, I may do a workup and whatnot. But I really try to think about it as a simple field. And in the setting of a metabolic disease, I always think about, in attempt to simplify it, what will kill the child and I can fix it now. Anything that will kill the child or harm the child and I can fix it now, I need to worry about it. I need to know everything about it. So in the setting of metabolic diseases, thinking back to my general pediatric board study time, I think many of the metabolic diseases come with hypoglycemia. So checking for glucose and fixing hypoglycemia is something I always think about. And then I know that hyperammonemia can certainly be a problem that is a little bit more challenging to diagnose and to treat. I recently came across a patient that had a metabolic disease, and it was a first-time presentation. And now I'm going to add another thing to the list. I guess the acidosis can really be a big problem. So maybe checking for that and fixing that. I'd love to hear your thought about my attempt to simplify metabolic diseases.
Yeah, I think that's a good summary. I would differentiate between diagnosed versus undiagnosed patients.
Sure.
And luckily, we're moving into an era of more and more patients get an accurate and specific diagnosis earlier in life. So part of that is newborn screening, which is continuing to expand and be improved upon. Part of that is the fact that we have access to really broad and sensitive genetic testing that we can use early in life now. So we're much more likely to diagnose patients with their first manifestations of illness as opposed to after multiple decompensations and multiple ED visits with no known reason for that. So for the patients that have a specific diagnosis, my hope would be that the metabolic and genetic providers that are caring for them have given the patient and the family a treatment plan and conveyed exactly what you asked. And that plan should convey what are the acute concerns, what are the things that could lead to death or permanent injury, and what are the ways to counteract that in the emergency room. And that'll be different for different metabolic disorders. But I also agree in terms of undiagnosed patients, very important in the setting of an acute decompensation to think about hypoglycemia, hyperammonemia, acidosis. Absolutely.
And so you agree, usually, at least in my hospital, getting a venous blood gas tells you the basic electrolytes, acidosis, yes or no, checking the glucose, take it from there.
Yeah, I think that's a good start. Awesome. Yeah, the hyperammonemia is really key, and that will rely on your clinical intuition because that looks like altered mental status. It looks like in young babies, it looks like sepsis or other things that are more common. And so that's one that you do have to kind of keep top of mind of being in the mindset of sending ammonia in the setting of altered mental status, unexplained decompensation, things like that. But that's one that's not going to be obvious based on other labs.
Sure. So kind of let's try to break it down. I'd love to hear what you think about sort of my algorithm and approach. So when I see a patient with hypoglycemia, and I teach the residents and the fellow about something called the rule of 50 to 100. So the dextrose content I give times the cc per kilo that I give has to equal 50 to 100. So for example, in most DRs, you can get D5 or D10 quite readily. So if it's D5, 10 cc per kilo, 5 times 10 is 50, perfect, or something like that. Does that sound reasonable to you?
Yeah, it does. And I honestly, I deal with this more in the setting of prevention and management once the acute circumstances have been addressed. So I really defer to your judgment and your approach in terms of the very acute treatment of hypoglycemia. One thing I will say is that both for patients with metabolic disorders and patients with kind of idiopathic multifactorial hypoglycemia, by the time they are clinically hypoglycemic, they are completely depleted of glycogen. So you can treat their hypoglycemia, and you can correct it for a little while, but they're going to go right back down if they don't have a continuous source of glucose to support them.
Sure. So maintenance IV fluids, sort of in a 1.5 rate or something like that, with dextrose, of course.
Yeah, like D10 containing fluids at a maintenance and a half rate could be a good way to support a patient and help them to build back up their glycogen stores after an acute hypoglycemic episode.
All right. So I identified hypoglycemia. I treated it, or I'm about to treat it. Before I call you guys, let's say I identified this is likely metabolic disease. There are other things that sit on our differential when we see a sick newborn, namely sepsis. Those kids almost always are hypothermic or febrile. Cardiac disease. Sometimes we think about congenital adrenal hyperplasia. That's fairly easy to rule out with the sodium and potassium. But let's say I'm thinking about metabolic disease. I'm going to call you at some point. What labs will be helpful to obtain before we call you guys to give you information?
Yeah, so in the setting of hypoglycemia specifically, I would differentiate your pretest probabilities based on whether you have newborn screen results back or not. The typical timing of that in most states is going to be around day 5 of life. So if you're seeing a patient that's younger than that, obviously that's not going to be that common, but also, you are seeing neonates in the emergency room. Then, kind of everything's on the table. We have not lowered the pretest probability for a lot of the metabolic disorders that can present with hypoglycemia. Once that newborn screen result is back, then the pretest probabilities shift. So in particular, that would be for fatty acid oxidation disorders. Newborn screening is quite sensitive. The most common one is called MCAD, medium chain acyl-CoA dehydrogenase deficiency. And in the acute setting, the things that you primarily would do would be to check LFTs in addition to having your glucose level. So abnormal LFTs should be present in the setting of hypoglycemia if it's due to MCAD, medium chain acyl-CoA dehydrogenase deficiency. The other nice thing about LFTs is that will also evaluate for a number of glycogen storage disorders. So glycogen storage disorders are not on newborn screening. We don't have a good biomarker in a blood spot that can test for them. So the pretest probability doesn't really change pre or post newborn screen. But for the glycogen storage disorders that present with hypoglycemia, the reason they present with hypoglycemia is because the body can't get glycogen out of the liver. So if the body can't get glycogen out of the liver, then there's glycogen storage in the liver that's damaging hepatocytes, and that should cause an elevation in LFTs. And another useful data point for us is presence or absence of hepatomegaly. So that could be, based on your exam. Although patients with glycogen as the basis for hepatomegaly, the liver tissue is very soft, so it's not. It's a less obvious exam finding than some other sources of hepatomegaly. Some other things that we check that can be helpful, uric acid, I don't think you would be checking that regularly. So that probably would be after you speak with a metabolic physician. Lactate can be helpful. So, that's pretty easy to get just on your blood gas. So that's included in the same device at a lot of places. And an elevated lactate could be consistent with, in particular, glycogen storage disease type 1, as well as some other rarer metabolic disorders that do present with hypoglycemia.
And what about the sort of the hypoglycemic labs that we always think about, namely cortisol, growth hormone, TSH? What about those? I know those are a lot more, more related to the endocrinological disorders, but would those be part of your workup that you will request in the PDR?
Yeah. So at our hospital, for example, us as the metabolic providers, we've worked together with the endocrine team, and we have a combined order set. So it's the hypoglycemia critical sample. So from the perspective of the emergency room providers, the understanding is at our institution, right before you treat hypoglycemia, take a minute, order the hypoglycemia critical sample order set, and that will get all the labs that you need, both for metabolic and endocrine conditions, because it can be incredibly valuable, in particular for endocrinology, a little bit less so for metabolics, but still true for us to have that sample at the time of hypoglycemia.
Sure. And I got to say, as an emergency provider, that is one of the biggest challenges, to have a hypoglycemic child in front of you and obtain labs, but not treat the poor kid. But I certainly understand that once you do treat the hypoglycemia, those labs are not as valuable. Is that right?
Yeah, absolutely. So, hyperinsulinism, for example. So, that insulin level is going to change almost immediately when you give the glucose. So that's so valuable to have that level during the hypoglycemia immediately prior to treatment. There are some studies of patients with CGMs, and I don't remember the details of how they did these studies, but essentially before people have neurologic symptoms, it requires a pretty severe degree of hypoglycemia for a pretty sustained period of time. So, if a child isn't acutely symptomatic, they may be a little bit altered, but if they're not seizing, or if they're not really in distress, generally it's okay to take a couple minutes to get those really valuable lab samples from the perspective of the underlying diagnosis, and then treat.
Sure. So moving on from the glucose, which again, I think most emergency providers are fairly comfortable or aware of checking, especially in children, and treating. I think the more challenging, and you correct me if I'm wrong, thankfully, the more rare cases are the cases of urea cycle defects, or children who present with severe hyperammonemia. What advice do you have for us, assuming I obtain ammonia, or let's say the kid is jaundiced, the bilirubin is high, and I suspect it? What is the best way to treat those kids acutely? Because I don't feel like we have very, very good tools for that, certainly not a lot of experience. What would you advise for that?
So the first thing to say is that the most common metabolic disorder that causes hyperammonemia is ornithine transcarbamylase deficiency, or OTC. On the boards, you'll read that's an X-linked condition. So you think about it in boys. It turns out there's a lot of symptomatic females as well. So it's still important to check ammonia in a female. You can't just think of that as an X-linked and male disorder. The other thing to know about it is it's not on newborn screening, or for the states that do try to screen for it, the screening tests are not very good. They're not very sensitive. So there are still a lot of patients with OTC that are undiagnosed. So that will often, as opposed to many of the other metabolic disorders that can present with hyperammonemia, that's one where the emergency room, we're really reliant on emergency room providers to think about that diagnosis and to check for ammonia, because that's really how it's going to present. In terms of management, if you identify a really elevated ammonia, the first thing to do is to reverse a catabolic state. So it's almost exactly the same as treating hypoglycemia. The intent is to raise the insulin level of the body, get the body into the signaling pathways that convey anabolism. We want the body to be using amino acids to build tissue, not trying to excrete them through the urea cycle. And that then will start to lower the ammonia in and of itself. We do have specific medications that can bind ammonia, and then it causes it to be excretable in the urine without requiring the urea cycle. So that's it's a very expensive medication. A lot of hospitals don't carry it because it's so expensive to maintain on hand. And that's something that would definitely have to happen under the guidance of a metabolic provider.
Excellent. So providing fluids, providing glucose, putting the child on maintenance with dextrose, again, should just, at the very least, temporarily help with a significant ammonia level.
Yep, that's a really good start.
And I imagine, Austin, correct me if I'm wrong, the same thing will be for the acidosis that accompanies some of those diseases. Because again, the child I saw just a few weeks ago, a newborn that came very ill appearing, he really looked, and I was discussing it with my resident, he really looked like he was in DKA. Clearly he's 2 or 3 months old. He's not in DKA. And it became very clear kind of early on that this could very well be a metabolic disease. But to my surprise, the sodium was fine, the potassium was fine. I think the LFTs were fine too. So I was really just dealing with severe acidosis. I gave fluids that maybe did look a little better after the fluids, but is bicarb a good tool to be using in those circumstances?
Yeah, it is. So a couple points that I would make. One is it's really helpful for us to know, first of all, the metabolic disorders will be anion gap acidosis. A non-gap acidosis is not going to be a metabolic disorder.
Excellent.
So that's a really good data point for us if you're calling a metabolic physician to have the anion gap available. So in terms of the anion gap acidoses, it's really either ketones or it's lactate. Those are really the only two acids that result from a metabolic disorder as opposed to like a toxic ingestion that can build up in sufficient quantities to cause significant acidosis. And that's super helpful to us to know whether is it a lactic acidosis, a ketoacidosis, or both. So that gets us pretty far down our diagnostic algorithm. In terms of the ketoacidosis, that will almost certainly respond to and improve with IV fluid and glucose. So that's a really good management strategy there. Lactic acidosis could be a little different. So I would recommend talking to the metabolic provider, but there are certain types of lactic acidosis that can be exacerbated by high dose glucose. So like, for example, pyruvate dehydrogenase deficiency is one of the more common metabolic disorders that causes lactic acidosis. That's a block at the end of glycolysis. So if you're giving more glucose, you're just building up more and more and more of the substrate that's leading to the lactate. So that's a more nuanced and complicated area there. In terms of the question of treating acidosis, I always like to make the point that the ketones and the lactate, that's useful energetic substrate to the body. Those are good things for the body. The problem is not the ketones. The problem is not the lactate. The problem is the acidosis. So I would want you to treat the pH. You're not treating to bring down the ketones or to bring down the lactate. You're treating to have a normal pH or a pH that's not acutely life-threatening in the sense of causing cardiac arrhythmias or other kinds of organ dysfunction.
Excellent. Austin, those were, again, super helpful tips. And I guess I should have started with that question. But the last question I have for you, because again, as you probably know, and this is especially true in Nevada, a lot of children, a lot of babies get seen by general emergency physicians. I mean, not all cities are lucky to have children's hospitals or pediatric emergency departments. What would you advise to the general emergency physician who is, again, mostly comfortable seeing adults, certainly not very comfortable seeing newborns, unfortunately? How do we identify by history and physical those very few patients with metabolic disease, first presentation of?
Yeah, I mean, you're absolutely right that it's going to be very hard, and you've alluded to this just based on the lack of repetition, the lack of experience with these very rare diseases. Each individual disease is going to be something that you'll see once in a career in the emergency room. So, yeah, I mean, I think it has to be a combination of an algorithmic approach with some clinical intuition on top of that. And if something's not adding up, if something doesn't make sense in terms of the illness script, if it just doesn't, like 9 times out of 10, it's going to be sepsis, or it's going to be just kind of a complex multifactorial hypoglycemia, not a metabolic disorder. But if you get those initial results and something just doesn't add up, I think that it's important to dig a little bit deeper and maybe consider some of these additional labs that we've been talking about.
Yeah, the way I again try to putting it simply, I try to teach my EM residents. I guess the way I kind of put it in my head, the newborn with the first presentation of metabolic disease is usually not hypothermic, not febrile, and kind of looks like he's in decay.
Yeah, it could be. So certainly for those ones that present with acidosis, very much could look for all the world like DKA, with the exception of the glucose. Glucose
Sure.
typically will be lower. For patients with hyperammonemia, that's very hard to differentiate from other causes of altered mental status. So, I think that might be just one takeaway for me, is just check an ammonia. If you can't figure out the basis of altered mental status, check an ammonia. It's available in almost every hospital. It's not a special send out order. And that can really be life-saving to identify that a few hours earlier, rather than when the patient gets to the PICU or out, beyond your care.
Excellent. Austin, thank you very, very much for your time. I really, really appreciate it. Again, something that makes us all pediatric PEM providers and not PEM providers very nervous, something that really sits high on our list of I never want to miss it, but can easily be missed. So really, thank you for your time. I know you did listen to the podcast in the past a little bit, and you kind of know the drill and the tradition. The guests get to choose the outro of choice. I can play, most rock songs, but I gotta say, you really surprised me with the list of artists. I guess they're in the rock genre, but I never heard of any of those. Mountain Goats. I can't even pronounce this one. Wakachi. Is that national vampire week? Say it again.
Waxahachie.
And one of the artists that came up was Vampire Weekend. So I think I got one song by Vampire Weekend that hopefully will make you happy to listen as a thank you for your time.
Great. Well, thank you so much. I'm really glad that you're doing this. This is a great resource, and really appreciate your interest and appreciate you having me on.
Well, we appreciate you taking care of those children with the rare diseases that we are not nearly smart enough to figure out. So I appreciate your time. Thank you very much. And always happy to do this again if there's something you think PEM providers can benefit from.
All right. Thanks, Yaron.
Thank you. And that is it for today, guys. Thank you very much for listening. I hope you learned from Austin and his wisdom. Again, super complicated topic that we don't see very often, therefore easy to forget and easy to miss. I think Austin's tips were very, very important. So thank you again. I hope you enjoy PEM Rules. Please check the website, check the Facebook page, check the store, and feel free to be in touch. All of you PEM providers are invited to come on the show and to talk about any PEM-related topic you think other listeners will benefit from. This is my attempt to do A-Punk by Vampire Weekend, a band I've never heard about. Great music nonetheless. Hope you enjoyed it. Thank you very much.